There we go.
Good morning. This meeting is called to order. Welcome to the February 8th meeting of the Douglas County Criminal Justice Court and Council. My name is Pam Weegan, and I'm the chair of the CJCC. I want to pass on a bit of information regarding how we will conduct our meeting on Zoom today. We ask that all members please turn on video if you have it. We ask that all members and presenters use good conference etiquette and mute their line when not speaking. We ask that you please identify yourself each time you speak. If you have public comment to make during the public comment section of the agenda, please use the raise your hand function on Zoom. Recordings of the CJCC meetings are available on the CJCC website after each meeting. We want to welcome all new members today. Our first agenda item today is a discussion about the ideal crisis-centered learning community with Bob Tryansky.
Pam, maybe before we jump to Bob,
Sure.
I know we've got at least a couple. I thought it would be good to introduce our new representative from the city of Lawrence, Commissioner Littlejohn. Welcome to the CJCC.
Hello, everybody. Commissioner Littlejohn, thanks for having me, and look forward to the conversation. Yeah.
Thank you. I appreciate it. I don't know if we have any other introductions that we need to take care of. It doesn't sound like, I don't think we necessarily do.
Okay.
I would say that Dorothy is here representing the DA's office. Suzanne Valdez asked if she could attend the meeting in her absence today. So that's why Dorothy's a part of our team today.
Great.
Thanks. Bob?
Forgive me for being slow. Can everybody see this PowerPoint presentation? And is it clearly sort of large enough and everything? Okay. I was supposed to do this at the last meeting, so thanks for the opportunity to loop back around and share with you an opportunity that's come to Douglas County that I think we should be excited about. In August, I think it was, maybe it was October. In October, we were approached by the Group for the Advancement of Psychiatry and the National Council for Behavioral Health to join a project that has been convened by several people, including Dr. Margie Balfour, who's one of the 3 psychiatrists on the consulting team from Connections Health Solutions, which has been kind of an advisory technical assistance team that's helping us design the crisis center. As you all know, last year, a work group, the mobile response work group of this council, the CJCC, came together to look at what might need to happen to bring 988, a 24/7 crisis line and air traffic control hub for crisis calls, along with a mobile crisis response team online in Douglas County. Those 2 components were identified as priorities of the Proposition 1 sales tax initiative that was passed several years ago. And so that work group came together to try to put together proposals for how we would bring 988 and a mobile crisis team online in Douglas County. I think it was Commissioner Portillo, when we shared this with the CJCC last year, who raised the question of, really good question, are you following any national models or blueprints or best practices for how you approach this process? And the answer was, we're looking at several models and we are reaching out to communities, but I don't think we were following a recognized model. We've now been asked to participate in a national learning community with 5 other communities. So it's Douglas County, Kansas. It's Iowa City, Iowa, community that has a lot of similarities to Douglas County. Grand Rapids, Michigan, Austin, Texas, Miami, Florida, and New York City. So we are being asked to participate in a community of 6 to consider adopting this roadmap as a blueprint for integrating a crisis system. We have made a lot of progress in Douglas County over the last couple of years at putting some key components of a crisis system together. And we're going to bring the Treatment and Recovery Center online in 2022. We're hoping to begin implementing 988 in 2022. We are bringing on an assertive community treatment team, assisted outpatient treatment, all the components of a comprehensive 24/7 crisis system. We've been doing that with a lot of energy and a lot of effort on the part of individual stakeholders and people. And some might, as you look at it from the outside, say it seems at times like we might be building a plane as we're trying to fly it. And in order to sort of have a well integrated system, we need to look at these components as more than just a collection of services. How do we take those puzzle pieces and put them together so that we are able to achieve what we've been saying for the last 4 or 5 years, an integrated system of behavioral health care that helps people to move from crisis and illness as a norm to recovery and prevention as a practice. So a crisis system is much more than a crisis center. It has all of these components, a 988 crisis line, mobile crisis response teams, a crisis facility, and then post wraparound services. So what we've done with the intensive care coordination team, some of the work that's going to be done by assertive community treatment teams. How do we keep people in the community, allow them to maintain stability and tenure in the community so that they are in the least restrictive setting necessary for them to be able to thrive in the community. We want to build a system that provides the right care in the right setting at the right time. And there are multiple moving parts. It's time for some conversations to pull together the key ingredients of a system. So what are the accountability mechanisms for this integrated system of care? How do we foster and sustain collaboration to develop an integrated system of care? And what's the role of data to inform and help us to measure progress and to look at whether our key performance indicators are being met? The crisis blueprint has 3 report cards, 3 sort of areas that they focus on. The first is accountability and finance. So how does your system provide governance and oversight of all the various components of the crisis system? The second looks at the service continuum and what are the array of services and capacities, the puzzle pieces that you're trying to fit together. And the third is, what are your clinical practices? And so what we've been asked to do is to participate in kind of a self-assessment of these 3 areas of the crisis system that we're trying to design. The team that is kind of leading this effort is Stacy Cooper, who was one of the co-facilitators of the Mobile Response Work Group. Dr. Matthew Cravens, who is our senior data analyst at Douglas County, Monica Kurse, the vice president of external programs at headquarters, Dr. George Thompson, who is the new medical director for the Treatment and Recovery Center, and myself. So this team of 5 is going to engage with this ideal crisis center learning community and the other communities that are involved in this effort. And then what we've been asked to do is to lead an effort locally to kind of take one step at a time at doing a sort of community self-assessment and sort of working through the report card and the components for implementing this ideal crisis system. So I just wanted the council to be aware of the fact that this is some work that's being proposed and moving forward. What we would like to do is take the mobile crisis response work group and kind of take the players in that group and bring them over to the CIT Council and the Stepping Up Initiative and kind of create an ideal crisis system work group with all of the stakeholders in the criminal justice space and in the behavioral health space to cohesively and strategically and intentionally put the pieces of this system together. So I'll stop there and see what questions the council might have. the deafening sound of crickets. Oh, Darren, sorry.
Yeah, I don't want to just leap in. Is there a potential timeline at this point for, there's, maybe I need to back up. I heard the assessment. Who within the team that's on that final slide, or second to last slide, is responsible for the assessment? Is it, and do we know kind of what timeline is being discussed right now for that? Just trying to kind of wrap my mind around would look like a lot of moving parts perhaps in the early stage.
Yeah, so we've had 2 calls with the folks in this learning community. And the last assignment that we got was to try to figure out and come back to the group with how you would sort of, how we would pull together those 3 specific groups. So my thinking at the moment, and it's just my thinking, like we will meet this week with the other 4 people on this team, is that we identify some key players from the CJCC and from the Behavioral Health Leadership Coalition to sort of be the assessment team for the accountability and finance piece. So there would be law enforcement players, first responder players, and then our behavioral health partners that have been so instrumental in doing this work. As I said, Darren, the next step would be to have the CIT Council Stepping Up Initiative, this kind of work group of the CJCC, look at the service array component and do that assessment. And then the third piece would be to assemble a clinical best practices team. And I think that work lives with the members of the Behavioral Health Leadership Coalition. So, at the foundational level on accountability and finance, it's probably members of the CJCC and the BHLC, and I would see us kind of coming back to this council with that proposed team, and to do the same thing with the Behavioral Health Leadership Coalition. So I would say that work happens in the next 3 to 4 months.
Got you. And just so I'm also clear, does that mean that there are sort of 2 trains running in terms of y'all are doing, that group is doing work that's Douglas County based, but are you also sharing with the broader consortium and kind of like Miami and New York and Grand Rapids as well?
Yes, and some of the purpose of that is to sort of surface and address some common challenges that communities around the country are confronting when they try to implement this comprehensive crisis system. One thing is there is no clear, blueprint for this. So this is an attempt to kind of adopt and to put a model in place. The second thing is, a question that we've raised is, how does a community of our size achieve this type of comprehensive system in a state that has no Medicaid expansion, and with a population that we have? We raise questions like that. Iowa City raises questions like that. There are other questions about how you incentivize multiple payer sources, so that you're not in Kansas and the TRC of Douglas County. We've got a model that is really heavily dependent on Medicaid funding as the primary revenue source. So it's trying to sort of surface those common issues and challenges and opportunities and pain points, quite honestly, to be addressed by this. How do you, for example, integrate mobile response, which is, a behavioral health clinician and a peer approach to reaching in the community? How is that enhanced by a co-responder unit that has law enforcement and a behavioral health clinician? How do these pieces all fit together? That's the purpose of the learning and the collaboration and kind of shared attempt to put these pieces together. I think they're interested in us and in Iowa City because it is really, we have a unique set of challenges in a community of our size, and some of our funding limitations to make this work happen.
I might have a follow-up that occurred to me while you're talking, but I don't want to monopolize, so I'll step back if someone else has questions.
I just want to thank Bob and Stacy and Monica and Dr. Thompson, the whole team that has initially been a part of this conversation, just because, this is really super hard collaborative work. when you're talking about our entire behavioral health system and our response to crisis and our law enforcement and justice related systems, and trying to figure out how do we work together better. So this is super complex and difficult work. And there's a lot of players, Bert Nash, Becca, law enforcement officers on this team that will all be a part of this study of how to improve our crisis system overall. And just thank you all for continuing to participate and letting us be led by kind of what is the national best practices and models that we should be working towards in this space. So just want to acknowledge the work. Thank you.
Other questions?
Well, I think Darren had a follow-up, so I just wanted to say it'd be a good time for him to jump back in with that follow-up.
Okay, I will. And I did want to echo what Sarah said. I think this is super exciting. I'm so glad to know that Douglas County is a part of this group. And I'm glad to know that you're already presaging those questions that, like my experience in New York is one thing in terms of the structure that's there. And so I'm thankful that you all are already asking the questions that make sense. I think the only other thing that I was curious about is there already a perceived step in that timeline or in that process to engage folks who have been clients of headquarters or who have experienced these portions of the system to kind of have those voices in the conversation as the discussion around what the crisis center needs from those who've experienced those services being able to contribute to the conversation?
The answer is yes. And one of the first steps of this was for each community to kind of give an overview of who we are, what we're trying to do, what progress we've made, where there are challenges. And integrating peer support, as you know, is a key component of our behavioral health and the community health improvement plan, integrating peer support across the system of care. So that is very much a part of the service array and system design questions. But then the issue, so there's how do we integrate peer support into service delivery? But the question of how we integrate the lived experience perspective with all of its breadth and complexity, right, into the decision-making processes and structures, that is a daunting challenge. And we've made some progress and we need to make a lot more progress. So I think, Darren, that's very much a part of the discussion. And it's also very much part of our discussions here in Douglas County.
Absolutely. Thanks. I just wanted to raise that. So I'm glad to hear that as well.
I think if we don't have any more questions, I think everybody's really excited about this opportunity and look forward to hearing about your progress as you move forward in that process. Our next agenda item is a presentation on SMI population in the jail and competency restoration with Sheriff Armbruster, Chief Judge McCabria, and Dr. Matt Cravens. And I think, Bob, you're filling in for Matt today.
You're muted, Bob. Okay, yeah, thanks.
Yeah. So yes, I am filling in. And so full disclosure and full disclaimer, I'm not a doctor. I'm not a data analyst, and I don't play one on TV. So that's bad news and the good news. The good news is I'm going to try to see if we can keep this as sort of publicly accessible. Whenever you dive into data, sometimes things get too complex. But as you know, the Stepping Up initiative was a commitment by Douglas County and the other counties that are involved in this initiative to reduce the number of people in our jail with serious mental illness, to reduce their length of stay, and to use data to drive the process of improving quality. When we started these initiatives in 2017, 2018, as the community was struggling with different approaches and perspectives on what to do about our overflowing jail population. Addressing the needs of people with serious mental illness in our jails was very much a part of the conversation. So Dr. Cravens and the Stepping Up group and the CJCC have made tremendous progress at lifting up local Douglas County specific data that helps us to understand what's going on in our jail. And this is a season, I think, of opportunity to start to pivot and come back around to how are we doing in terms of addressing the needs of people in the jail and reducing our jail population and the number of people that are booked into the jail. So there are 4. This is the Stepping Up Initiative dashboard that is now publicly available. I will put the link to this in the chat. I'd like to do that while Judge McCabe is talking so I don't have to push too many buttons at once. We want to take a look at 4 graphs this morning. And the first one is the serious mental illness bookings, SMI bookings into the jail. So this graph covers the time period from 2014 through 2021. And what you'll notice is between 2014 and 2018, we made a tremendous amount of progress in reducing the number of people who are booked into the jail. There are some reasons for that. There's a collection of reasons for that. Everything from bringing a co-responder unit online, implementing behavioral health court, the assess, identify, and divert program in the jail, embedding behavioral health clinicians and SUD specialists into the jail. There were a whole series of initiatives that were taken between 2014 and 2018, which is one of the reasons Douglas County was recognized as an innovative county because we had made so much progress. In 2018, as we put together the behavioral health plank of the community health improvement plan, one of the objectives in that plan was to reduce this number by 10%. And so the CHIP objective is to reduce the percentage of bookings from 5.5% to 4.95%. So this is a good news line. Here is a challenge line. Between 2018 and today, the number of people booked into the jail has actually increased. In fact, got to a point where it was more than double where we were. And so, I think this is a call to attention or an opportunity to sort of say some more focus on how we're doing and how we intend to get from where we are to where we want to be. Raises some interesting questions. If you were to take the 18% and scale that down to where we are today, that would be significant progress. But one of the questions we should be asking is what's responsible for this? And so we just wanted you to see that there's quite a bit of distance still between where we are today at 8.8% and our target of 5%. What questions do you have on that? Again, keep in mind, I'm not a doctor and I don't play one on TV.
Hey, Bob, this is Rich Lockhart. I had a question. That seems like a little bit of an outlier. Are we sure that that number is an accurate number?
This 18 number?
Well, the 18 does too, but the 5.5 does as well.
Well, this is where we hit this number.
Okay, so that's good data.
Yep.
Okay, that's what I was asking.
Yep.
What about the 18? Are we sure that's not an outlier?
There's some questions about how we got there. This was the starting point. Sarah, can you jump in here maybe with the Husky report?
Yeah, I mean, I would say that there is I think there is some concerns about the data at that point, but I would say, Chief, like this is really where we started from. And that's why we had a call to action here, really to do something different in our system. So I think it's important we decided instead of trying to necessarily critique the data so much to get from 18 to 15, we should just begin to do the work that needed to be done to manage the system overall, which has led to the progress you're seeing on the chart.
Gotcha. Yeah, it's great progress. Those two numbers seem kind of out of whack with the other ones. So I was just curious, since I wasn't here, about the validity of the data for those two numbers.
Well, there's been a ton of work in that meantime since 2018 and 2021 to do the work. And I think that's part of the conversation that we would like the CJCC to spend a little more time and focus on in the next year.
Thank you.
And the reason for that sort of straight vertical line is that these other data points are not available between 2014 and 2018. It's like, here's where we started, here's where we wound up. Now, sort of, if you look at quarterly, here's where we've been over the last 4 years. Okay,
Bob, do you want to facilitate that? You've got 2 questions up there. So if you can't read them,
I
Commissioner
can't read
Little-
them because I've got this graph and then
Okay.
a little panel of,
Why don't you just close the screen now and then we can take some questions before we move on.
great.
Bart, if Commissioner Littlejohn, if you want to go ahead and that'd be great.
Yeah, thank you. I appreciate that. One, I'm encouraged because it looks like it's trending down, which is awesome. And then also, it looks like, I was just kind of, what do we anticipate it being, in this upcoming session? Because it looks like around the turn of the year, there's always a downtrend. And I'm just wondering if there was any sort of anticipation or forecasting of that. Otherwise, replying to what Chief Lockhart said, those other 2 points seem like outliers, but that the only other point that really concerned me was like the 13.4 that was in the middle of the graph. That was a pretty big spike. Do we have any surrounding information on why that went up so much at that time? Sorry, that's a bunch of questions.
So I know that one thing that was raised with this council when we looked at the last time the data was looked at was that there's a period of time where the co-responder unit has not been, as readily and reliably available. And there was some speculation that that was impacting things. The other thing is that we did bring on a embedded team of behavioral health clinicians in the emergency department. And there was some speculation that that was having a positive impact on our jail booking numbers, but that's, anecdotal correlation conversations that have been happening. No sort of analytic precision to that. And here I'm talking outside my scope of. Commissioner Portillo.
You used all the right words, Bob, so I appreciated that.
Excellent.
I just wanted to read the question in the chat and add to it a bit and remind folks that because this is an open meeting, let's please not put questions in the chat and please verbalize them. But the question in the chat asked, did the pandemic affect bookings? And I'd like to extend that a bit. We know that mental health has been a struggle for a lot of folks during the pandemic. There's also been quite a bit of pressure on healthcare providers and mental and behavioral healthcare providers during this time, and we've seen churn in both of those fields. So how are we preparing for both kind of past effects of the pandemic and current, where we're at now in the pandemic, and from a staffing standpoint? Because this is working with a number of partners throughout our community. Are we seeing those effects, and what can we do to help kind of buffer and prepare for those?
I'm going to turn to maybe Patrick Schmitz and Lori Alvarado to speak from their perspective.
Patrick, you want to go? You want me to start?
I'll let you go first.
Commissioner Portillo, I think you probably know the answer to your question. It's been a huge challenge for clinicians, support staff, even our residential floor staff. COVID has been a challenge for how we provide treatment. It requires us to social distance. It requires us to use electronic devices, which we know are generally not the best at engagement when you're talking about some of the issues that we're dealing with. There is high competition for licensed staff of all levels, high competition in this community, high competition in communities surrounding us. Wages are becoming hugely competitive, while rates for reimbursement continue to lag. So it's hard to compete for the right kind of staff to do the right kind of work. And beyond that, they're just tired. They're tired. They're tired physically. They're tired mentally. They're tired from dealing with things in their own family that they may have to deal with because of things that happen in school systems or with their, significant other work environments, right? All those things. And so from my perspective, it's been hugely challenging to continue to do quality work But I will tell you that those who do the work are passionate about, I have people who are incredibly passionate about substance abuse work, and they come to work every day, and they do the work that is required to do, and they do what they're supposed to do, and they do it with compassion. They do it with skill, they do it with accountability. And while it's a challenge, I can say that I have very passionate, caring, effective staff. Is it easy? No.
I would echo everything that Lori said. If you think about the collective stress level and anxiety of our nation and our world since the pandemic, it all raised up, right? Just your general functioning, worry about going out in public and catching something that could potentially kill you or a family member. That our staff are not immune to that same experience when they go out or when they bring people in to serve them. So they have that level of anxiety that raised on top of the work that they're doing. The level of anxiety and chronicity and challenges for the clients they've served has also increased. So they're dealing with a much more challenging set of clients, and then the sheer volume of those clients. So very similar to what we're seeing across the street at LMH Health. They're dealing with a lot more and a lot more severity and challenging at their own risk and peril. And as Lori said, the opportunities for them have just exploded. We quickly shifted all services to virtual. We taught them how to do it, and they discovered they could do it on their own somewhere else for a lot more money, or from their living room or their office at home for some other company. So the number of them that have had opportunities to do something different at a higher pay and maybe with less challenging clients has presented itself. You've seen a huge increase in the number of online apps that will connect you to a therapist. So the opportunities are significant. And as Lori said, the people that do this work are really dedicated to it. It's really challenging because we are here to work with really difficult situations. Every day, our staff are dealing with people's who are either reliving or experiencing the worst moments of their life. The worst periods of time, and they're sitting in that room, whether it's virtual or realistically in person, and dealing with really challenging stuff, and that weighs on them. And so what are we needing to do? We need to wrap more supports around our staff. We have to find a way to improve the reimbursement for our staff so they can afford to live and do this work with really challenging people. Because, you know, I'm sure for Lori's very similar. We tend to be the training ground for a lot of new clinicians, and then they move on. And we need to be able to train them and keep them to be able to work with those really challenging people, or people, I shouldn't say challenging people who are dealing with the really challenging things. It takes a lot of skill to do that work. And those that stick in it are exactly what Lori said. They're super dedicated to this work. They see it as their life's work, their passion. And so we just need to continue to identify more and more of those people and then support them in doing that work.
Commissioner Portillo, I think there's one other component. I mean, there's several components, but data helps. And one of the pieces of data that I have been looking at with the LMH team, Bert Nash, DECA, and our friends from headquarters is the number of suicide attempts that are coming into the emergency department, and the number of people who are coming in the emergency department with suicidal ideation. And those numbers are sobering. There's been a significant increase in the number of particularly young people under the age of 19 who in 2020 and 2021 have come into the emergency room with a suicide attempt. And the numbers are similar in the realm of suicidal ideation. That's one lens, one perspective, but it definitely shows that people are under more pressure and things are getting to the point where there's significantly more risk involved in the struggles that people are having, I think.
And thank you, Bob,
I would
for
agree.
bringing that back to the data piece, because I really appreciate how those data demonstrate the strain in our community. And I think Lori and Patrick have done a fantastic job of really articulating the strain from the provider side. We know that reimbursements aren't going up, but the cost of employing really quality folks and retaining really quality folks in these organizations, those costs are going up. And so what are the strategies that we can put in place as a community to make sure that we have the services necessary to provide for a growing issue? We know that we want to keep those numbers low. We want to hit that 5% mark within the jail, but part of that is making sure that we have the resources within the community to make sure that folks get the behavioral and mental health care that they need. And so I know that I think we can all articulate the problems from each of those perspectives. And I'm just curious of what resources do we need to provide to make sure we have solutions?
I think that's an excellent point, Commissioner Portillo. And I think that's why the work here of the co-responder program, and we have a CIT council, a co-responder program, a mobile access team, and then you already just heard about the conversation about the communities of learning that we're involved in. This data means that we need to come together and examine new strategies for how we're going to deal with this work. We did some great work in 2019. Maybe we need to make the next evolution of the flywheel based off of the pandemic to figure out how we can improve our system moving forward. So, I think this is why we brought this data forward, and we have articulated the problem. Now this is really the group of people that need to examine the strategies to get us there. So I know that there's been some conversations, Bob, with the CIT team. There's been some transitions in leadership. I know that it would be really great to put some additional emphasis behind that work moving forward, to help bring some strategies that could come back to this group for consideration.
Well, and I think that's an excellent point, Sarah. And, one of the questions is, as we bring mobile crisis response, the mobile access team online, how is that team supported by, and backed up by law enforcement? So we don't want law enforcement to be the first point of contact in the community, but we know that there are often safety concerns and the need for de-escalation in these situations. And so we don't want to put, a team of behavioral health professionals out there without knowing that they're going to be supported and backed up by EMS and law enforcement. And so, the co-responder program is a 10 to 7 Monday through Friday program. We're trying to go to 24/7 with our crisis response. So everybody's going to have to stretch here, and everybody internally is, I think this is a good time to look at our budgets and ask ourselves, how are we focusing priorities so that we can collectively reach this community aspiration of having a 24/7 well-integrated crisis system.
Bob, I would also add to that is the need for us to continue to focus on how do we better support our youth, and not less, but more. How do we keep the services that they need available to them? We're faced with a situation now where there's less resources to provide care for them at a time when they need even more resources. And the pressure point on that is significant. And we're seeing that, as you mentioned, in the data at the ED, in terms of the increasing number of suicide attempts and ideation in our youth, and the increasing number of kids who are just struggling to succeed in life. And this has true generational decades of impact if it's not addressed sooner rather than later, because they get into a pattern, they get into a mindset, they get into their mental health is truly affected if we're not intervening sooner and getting them on a better path. And then they end up needing these more expensive, higher level services. So that's another thing we have to continue to have a conversation about and true solutions for. And I'll turn it over to Lori, because I'm sure she's got something to add.
Well, it's interesting because you highlighted the things that I would say too. If we're going to break the generational kind of impact that Patrick said of, and not just like, I'm talking about if somebody starts having challenges when they're 8, 9, 10, that has decades of effect on their life, right? If their life expectancy hits the level that we know that it can. So I'm going to say what I've said several times in this room, and people are probably tired of hearing me say, but we really have to get into prevention, and prevention isn't after the issue starts. Prevention is before the issue begins. And I believe this community is primed and ready if we're prepared to show, if we're prepared, as Bob said, to look at our budgets differently and really intervene early before the trauma gains hold in someone's life. It's critical. And I think that's an area we probably have not tackled as well as we could in this community to really knit those services together for all of our citizens. And then the other thing I would say is a data point that might be interesting to look at in our community, our county. Overdose deaths have skyrocketed 25% higher than they were a year ago. That also feeds into suicide ideation. That feeds into some of the other things that we're talking about. Also feeds into our crisis response if you're talking about folks who may be in an overdose situation. Those are all things that I think if we lay data over, we would find some things that are interrelated and connected and require an interrelated and connected response.
So I don't want to cut the conversation short because it's an important conversation, but I want to make sure that we stay focused. And I want to get through all 4 of these graphs because we do want to focus on our jail population and what is happening with the SMI. So in the intercept 0 in the sequential intercept model, right, there's been a lot of progress and opportunities still for more progress on bookings into the jail. But let's also take a look at length of stay. So as you'll see, there continues to be a pretty significant gap between the length of stay for individuals with SMI, which is the blue line, and the average length of stay for all other bookings. That number has, fluctuated, and there's been quite a bit of disparity at times, 49 and 40%, but there's still pretty significant difference between the length of stay for somebody with a serious mental illness and somebody who does not have that as part of their profile of challenges. Also wanted to just highlight that if you look at the percentage of people in the jail with SMI, presently, our latest snapshot between October and December, that number was at 25%. I know Dr. Cravens is going to take and sort of sketch this out a little bit over time to show how that percentage has fluctuated. I think over the last 3 years, it's been as high at times as 33%. I know the last time we took this snapshot, it was at 28%, but a quarter or more of the people in the Douglas County Correctional Facility have SMI, and that is a significant part of our population. There's also a racial disparity component among that, and so then go back here. I don't have this on a graph, but I have it from Dr. Craven's notes. 39% of the people in this 25% are Black. And so that is a very significant disparity that we ought to pay attention to and ask ourselves what is going on there. The last piece is recidivism rates of individuals with SMI compared to all the other people in the jail. And there's a fairly significant disparity there in terms of repeat bookings and people returning to the jail when they have a serious mental illness. What questions do you have on that? We want to talk about one other contributing factor to some of the challenges we face, and that is competency restoration. But let me pause there and see what.
Well, on the recidivism piece, Bob, I know that we're talking about reentry in our community, and I know the sheriff has a reentry program that's coming up later this spring, but how are we kind of focusing on that reentry time for folks with SMI to make sure that we can target that as a way to reduce recidivism?
Carrie, do you have some things you want to like to share?
Yeah, sure. I'm Carrie Nice. I am the reentry director out here at the jail. So what I will say about the SMI population is we have on our mental health team from Burt Nash here at the jail, we have a designated clinician that works directly with that SMI population. And they will collaborate with a case manager on the reentry team. And then we have DECA in that piece as well, so that we can all collaborate together and try and set up the best release plan as possible. I will say that it is very challenging to find housing and set up things in the community when people are facing these kind of challenges. But we do work together as a team, and we kind of have all the pieces to the puzzle. We include the members in the community, maybe case managers they've worked with in the past, if they have a payee, or if they have family members that are willing to assist in the process. We engage everybody in that process to try to get them where they can be successful.
Thank you.
And there are, Commissioner Portillo, we've had a number of housing initiatives. So, dedicated beds at Bridges has been part of the reentry and the behavioral health court model. Artists Helping the Homeless have brought 2 projects to the community. One is Kairos House, which is, transitional living for people coming out of reentry. And they've expanded also to Meraki House. So we now serve 16 men, more than we did 3 years ago. And there's a real need for a similar type of model to address the needs of women who are coming out of the correctional system. Marielle.
I have a question when you finished with your data discussion about the fact that racial disparities are continually showing up and how we're needing to address that. And so when you're finished, I'll ask.
Marielle, do you want to go first and then we'll come back to Tamara?
Yeah, sure. I just wanted to make a quick comment on the reentry team, and just wanted to thank them. They've recently partnered with the Housing Stabilization Collaborative and will be coming into our landlord engagement meetings. So we will start deepening that discussion. Reentry has been the sore spot in providing housing for our community, and it's been difficult. Also, the supportive housing assessment that's coming up, there's a lot of planning and work to use the ARPA funding to hopefully get some more building established for housing that would be centered around supportive housing. So there's a lot of really good conversation and work happening right now. I apologize, my phone's going off right now. So there's a lot to look forward to. And I just want to thank the reentry team for utilizing all of the points of access and resources that they can. So we're very excited to have them participate in the meetings. And hopefully, I know housing is the big issue with reentry and with folks repeating and coming back to jails. They're not getting that service met. So hoping to expand more on that and really engage the community and maybe start engaging more of our area property managers and landlords on how they can be a part of the conversation too. So just wanted to make a comment, and thank you.
Thank you, Marielle.
Tamara.
Okay, as we have sort of acknowledged all of the racial disparities in the jail and in terms of serious mental illness. And I'm wondering if there has been an opportunity to consult with a therapist or therapists who specialize in racism as trauma. And, you know, how we can get to the point, you know, I understand the intersection of housing and mental illness and all that, but do we need someone who specializes in that area? Because there are therapists who do. Has anyone thought about that? Because I guess I'm looking for, there are a lot of individual programs that look at this issue, but do we have a concerted plan about how to change these numbers? Does that make sense?
It does. I'm trying to figure out where to place that question so that somebody could come back with an answer.
Well, I don't know. I personally, I think I'm going to be looking to ask for therapists in the area that do touch on this issue, because it's an issue that didn't just come up yesterday. It continues to happen. I think people recognize now that, you know, racism and the policies that surround racism, intentional or not, are the ones that repeatedly put people in harm's way, physically, mentally, emotionally. So I think we need to be talking to people who specialize in that area to guide us. And perhaps to help treat these people.
I think that's an interesting idea. I think we should look into it further. I know that one of the things we're talking a lot about is the number one reason people are in jail is failure to appear. And so we're trying to figure out how can we fix this problem of not attending hearings, because it's the number one reason people get there. And I know we've got several committees looking at that, trying to figure out, I mean, if we could kind of do some of the low hanging fruit in terms of improving attendance in court, it'd be huge.
I guess I'm thinking too about even before they get to the jail, what can be done to, because this is a childhood thing, and it's I think some of you mentioned previously, it's generational. And so it seems like there should be more of a concerted effort to get treatment that is directed at the dramatic effects of what has been happening for decades and centuries.
Yeah, so therapists that understand the dynamics of generational trauma, the systemic impact of racism on a person's mental health and options, and again,
physical health.
Yeah. I'm just trying to figure out like what would be where would it be a good place to place a conversation like that? Because I think it's an excellent point.
You know, I think that, you know, I think that's something in Tamara. I think Tamara's on the racial disparities work group, and I think a conversation between that and maybe some of our friends over at the Behavioral Health Leadership Coalition as we think about our community health plan, and you know, the designation by our public health board as racism is a public health crisis. You know, there's some collaboration and some synergy that can come through that work if the focus is trying to be, you know, preventative and community based as opposed to criminal justice based necessarily. So Tamara, I really appreciate that. And I think that sounds like some work that maybe we can talk over in that work group as to where would be some good next steps.
Okay. It's important, I think, to address them both. I mean, people are already in the criminal justice system, so you can't ignore that, but there need to be some preventative measures, I think, and starting with young people, and or looking at them while looking at their parents. I don't know. I will bring it up in the racial disparities work group, and I also would just kind of do some kind of looking around and seeing if there's anybody in our region who purports to specialize in this area.
Shay?
Thanks.
I didn't have a response to that, but I do wonder if, I'm assuming that we can get a breakdown of the charges of that 25%. If we can determine what that 25% is there for, I think that I want to see if that also answers a question about whether or not there's a racial disparity in that group.
Yeah, and I know Dr. Craven, I have that, but I would rather have Dr. Cravens walk you through that and respond to questions on that because he's done the work to break that down. But I know that that's been done, and I think that's something we could bring back to this group when Dr. Cravens is here to walk through that. If that's amenable to you, Shay.
No, that's great. Thank you.
So the last piece I'd like to pivot to is to follow up on a concern that was raised several months ago by Judge McCabria about competency restoration and the challenges we face when people are sitting in jail waiting on a bed at Larned to be able to go through the process of competency restoration. Judge McCabria raised this question several months ago. What opportunities are there as we bring all these pieces of these new pieces of a crisis system online? And Judge McCabria, Sheriff Armbruster have really been taking the lead in moving this conversation forward. So I wanted to take a moment to give some space to the judge to kind of update on what we've been working on and where we might go in this realm.
Well, Bob, thank you. And thank you for all the work. I mean, whatever credit Bob just extended to me, it's my perception that Jay and Bob in particular just have the passion for this. I want to frame it just a little bit before I start speaking about it, because I want to draw a line of demarcation. We've already heard people talk about earlier in the system is where the most effect can be. And by the time people are booked in the jail and charged with a crime and in our courtroom, and we realize there are competency issues, the time and expense and the return on your dollar investment is the lowest at that point. So I just want to say, Bob's, the whole idea of bringing the crisis center to the community is such a massive help in all of this. And when I became aware that that was happening, this recurring longstanding problem came to mind. And so that's what prompted me to bring the question to him, always with the understanding that I know that's not the purpose of the primary goal or purpose of the crisis intervention. We've talked about all the things that have prompted that and that we hope that those things address. But I thought, well, I might as well ask if there's a piece that we can start thinking about early for addressing this competency issue. And just, again, to sort of frame it, people are booked, people are charged with crimes, they get first appeared, have an attorney appointed, and the legal process of the case starts. And usually it's the attorney who's been appointed to represent the person, but sometimes, it becomes apparent in the proceedings that this person's ability to understand the nature of the charges against them, the nature of the process that they are being asked to participate in, or something that because of a severe or persistent mental illness, they do not have the ability, it wouldn't be fair or right to just continue the process because they cannot meaningfully participate. And so the court orders a competency evaluation. This is controlled primarily by state statute. That first step is for the local mental health providers generally to be the resource to provide that. And, there's sort of a one lens view that is the accepted standard that those mental health providers are asked to utilize. It works in most situations, but if I had unlimited time and resources, there might be other things to explore there. But the initial screen happens, and there's the opinion that's presented to the court and to the attorneys from that professional. Does this person have the capacity to understand such that going forward is occurring within constitutional bounds? I don't know the exact breakdown on how often it's the case that they return a finding that the person is in fact competent. And lawyers aren't experts, judges aren't experts. So we raise the concern, we have the expert involved, and then, we get those reports back. Generally, the report is what everybody's relying on. There is a process where we could have a further inquiry or further hearings on that. But the sticking point, the concern that's been, and it's certainly not a local issue, it's statewide, it's been a growing concern around the state. There's essentially one place where people who are found to lack competency are sent in the state of Kansas, and that's to Larned State Hospital. And their ability to absorb that from around the state over time, for a variety of reasons, all of which have been discussed here, has continued to be challenged to the point that we have people, I just shared that or asked the sheriff to update it, so let me pull it up here. As of November of last year, we have 13 people awaiting a bed at Larned State Hospital because the initial screen said this person doesn't understand. And then there's a protocol where that person needs to be, there's an accepted protocol. Larned certainly has that expertise, but getting the person there, we've had people waiting since January of last year to get into Larned. And that creates all sorts of challenges. What do you do with these people while you're waiting? Because you're the default around the state, and to a large degree, even in this part of the state, has been, hold the person because the wait time was 60 days, 90 days. We didn't have a safe place to put them. As it got longer, the courts here started doing evaluations of, okay, not competent to assist in your defense is one aspect of a person's mental health issue. The second question is, are they a present danger to themselves or others such that we can bond them into the community? Our court services officers have been creative sometimes in finding ways to help give the court assurance that, there's going to be some support for the person while this process is playing out. But that's loading onto an already challenged system, and the obligation of the court is to get the competency issue resolved quickly, as quickly as circumstances allow. So that's what prompted me to say, Bob, are there aspects of the crisis center that are going to be available? Because the challenge is these are folks who need some pretty high level attention. It often involves mandatory medication, group and in-person therapies. So when I say we make evaluations of whether certain people can be bonded into the community, there's some, but not a lot because of the circumstances. And so the statute allows for somebody other than Larned to do it. I guess there's a lot of ways to say it. One way would be resources for this have not been something that lots of communities have been willing to dedicate resources to. And so Larned carries that load. So that's sort of the background of what the issue has been and where we stand. So since reaching out to Bob, and I know it's been an issue that Sheriff Armbrister's spoken to me about because it creates challenges at the jail. Again, those are things we've heard about. What's available? So Bob started talking to the professionals that would be coming on board with the local crisis center. I reached out to Larned because obviously they're the people who have a lot of experience with this. So I wanted to know, what does it take for this competency protocol to occur? What's the average length of time? What are the resources we could, use to make this operate? What are the flexible options for it? One thing that I was very glad to learn is that Larned has partnered with Sedgwick County and Shawnee County to start trying to address this at the state level. And that is through what they're calling their mobile restoration pilot program. So I've been in touch with the chief judges in both of those districts to inquire how that's been going. What I will say is the aspirations are good. The implementation is still sort of getting worked out. It's been somewhat helpful, maybe not to the degree that if it's fully up and running and they get things worked out, maybe that will be another option for us. But it doesn't mean we shouldn't continue to pursue local options. I believe we're probably going to get into that program pretty shortly, at least, and that will help us gain insight into what local resources we might be able to put towards this with the options of the crisis center. But I go beyond that and say, I started the conversation with Bob because of the crisis center, but I think it's certainly possible there's people on this council who may have other ideas or options. Sorry, the generator for the building gets tested every Tuesday at noon and just came on behind me. So I don't know if it affects your ability to hear me, but so I think we're making a lot of progress on getting Bob's team educated on what it would take, getting ourselves involved in the pilot program. All of our judges are on board. I don't have a definite timeline on what to expect because, again, we recognize that we're not in the front of the line when it comes to utilizing the crisis center, but we're exploring those other options. I know Bob's had some conversations with folks.
Judge, can we just to sketch some of those out? Because, I appreciate that you're giving me a lot of credit for trying to wrangle this effort. But the reality is that we've actually had quite a few conversations. So conversations with Dr. Dodson from Burton Ash and Dr. Thompson, who is the new medical director of the TRC. A request that we pull together a team that would be Dr. Dodson and Dr. Thompson and the team from Burton Ash, so folks like Sarah Godinez, who's involved in the competency screenings, and so I think the next step is to pull that team together and then to have that team interface with the team in Sedgwick and the team in Shawnee about their pilot projects and what they're doing and what they're learning. Judge McCabria did reach out and we met with Assistant Commissioner Bruner at KDADS and the Larned team. And then I followed back up with Commissioner Brown. And it's been communicated to us that KDADS would be very interested in entertaining a proposal from Douglas County as to what we might want to try to do in Douglas County. So I think our team has built a good on-ramp to conversation. I think we've got all the key players in place. And what we need to start to do now is sort of see if we can get a little bit more concrete about what we might want to try. I also know that the Governor Kelly's proposed budget has at this point a $2 million line item in the proposed budget to address this issue statewide. So, we may be pulling some things together. We're not going to do competency restoration in the crisis center. That's not going to be the appropriate environment, but that doesn't mean that we might not be able to take steps with an individual who is going through a competency restoration process that they might be able to receive services or treatment at the crisis center. We're going to explore what those options are, but I think it's really important to emphasize, let's not make any assumptions about what might be possible or what might not be possible. The point is we've assembled all the players to have some thoughtful conversation about what we might be able to do at the local level to relieve the pressure from this problem that's created at the state level. And I know Sheriff Armbruster, you have some thoughts about that as well.
Yeah, I'll be brief because they've covered everything, but really the main thing to me is that these are non-convicted people serving county time because the state requires it, and the amount of time they spend is exorbitant and getting longer, and the cost to the county taxpayers is immeasurable because these are the highest resource-driven individuals that take the most resources from us. And I've out of this group, I've become kind of the de facto trash can kicker in that I've fired off letters to all of our legislators, AG, everybody basically demanding that they begin to look at this. And I've gotten a lot of feedback because the state has no incentive to fix this issue. And because the county just continues to do what we've always done, and that is do the right thing and handle this situation on the county's dime while the state continues to do their thing. This happens in many different facets, but this is the one that's really shown its reared its ugly head to me. So I don't, and the thing is that Douglas County has the most people on that waiting list in the state, yet the state chose to go to Sedgwick and Shawnee County for these pilot programs. But when I reach out and say, hey, we have the most on here, what are you doing for us? Oh, we could try this pilot program, which we still haven't seen. And so it just feels like the state hasn't quite put their money where their mouth is. So I'm trying to be, for lack of a better term, the heavy on that, and in keeping it in the conversation at the state level to get them to try to address this issue, because I am very fortunate in that the jail facility that we have is able to handle 11 folks who are just, they're severely mentally ill. But if you go out 3 counties over, 1 county over to Jefferson County, say, or go down to out to Rooks or Thomas County, one of our SMI detainees in their jail would completely disrupt their entire ecosystem, and they could not handle it. And I've heard stories from those sheriffs about what they have to do just simply to keep them safe. And it's just not right. So it's a fight that I'm taking on as Douglas County, but I'm also taking it on from a sheriff's office and a statewide, because they don't have the people and the resources to do the things that we fortunately can do. So any questions you may have about what I'm doing or where I'm doing it, I'd be more than glad to talk about it, but I'll just kind of leave it at that, because that's not really what this meeting today was necessarily about.
Well, just on Jay's point, the reason you see that disparity in length of stay between non-mental illness inmates and people with SMI, a large contributor to that is those are the folks that are getting evaluated for competency, and they're on hold basically until we can get them through the LARNed funnel. So.
Will the group that is studying this locally be looking at the individual measures that are used to determine competency or the lack thereof? Because, I personally don't know which measures are used. I know there's there are IQ tests and whatever, but can we look at that?
So, Ms. Cash, what I will say is that's a legal standard that's been created by case law primarily. And when I said earlier, there's sort of one standard that is accepted. It's, does the person understand the nature of the charges, and do they understand the role of the parties who are participating? Do they know what the judge is supposed to do, what their defense attorney is supposed to do, what the prosecutor is supposed to do? So it's fairly generic. My concern, though, is there are people who can answer those questions correctly, but still have other challenges. And
And Judge, I'm asking the question because prior to my retirement, I was a school psychologist and administered IQ tests. And I know how people function or don't. And when someone scores a 75, they're certainly going to, as opposed to an average range of 90 to 110, there are going to be questions about how they problem solve. And, I remember hearing a previous official in Douglas County saying that, well, if they score 75, they're, with it enough to be able to function. And I certainly beg to differ with that. But that's the reason I'm asking, what are the tools that are used, and, are they appropriate, or does that need to be looked at some point, especially for those people who are maybe culturally different from what is considered the norm, typical? So is there a way to look at a list of of tools and measures that are used to determine competency? Or do I just need to do that as an individual?
I presume that anybody on here who's Sir Godinez with Bert Nash, it's the same protocol each time. And if I could pull one up, I could tell you the standardized tools she uses. So I'm sure it's information we can share.
So I maybe need to just talk to someone at Bert Nash.
Shay, do you have something?
I was going to say is I think what Ms. Cash is referencing and sort of what the judge was saying are basically tied together. The standard for whether or not they are competent, so those who are waiting to go to Larned, is so minimal that I can, for instance, I have a client who knows what he or she has been accused of doing, understands what my role is, understand what the prosecutor's role is, and understands what the judge role is, but thinks of themselves as something other than human. They are competent for purposes of going to trial. Now, if you look at all of the circumstances, and I'm trying to address something with bond, they're not someone that we're going to be comfortable, or at least in general, that most people are going to be comfortable having out in the community at large, because there are safety concerns there when they don't consider themselves to be human, right? But the standard that is applicable for the statute to determine whether or not they're competent is completely different to whether or not they can realistically assist in their own defense. They're not the same thing. So the standards that you're talking about, unfortunately, the way the system is set up about what their level of intelligence is, their ability to understand, they do not provide legal defenses generally. They may come into play once they're convicted at the time that we are trying to talk about what's an appropriate sentence. But generally, they will not alleviate them from having criminal responsibility. So that's a different question. That's where we try to pursue behavioral health court if we can, or pursue something else, because the answer that makes sense logically to me, I'm just going to talk about myself, logically to me, is not the legal standard that we have here in Kansas right now. And it's something that all of us and on this other end of it are obligated, right, to follow the statute. The court has to instruct the jury on what the statute says. I can only file a defense based on what I have, but that's not a legitimate defense. So I think that there are standardized protocols, but ultimately I don't think they're answering the question that we have. And it also explains why you have such a large number of people with SMI still in custody, even if they're not waiting to be sent to Larned.
All good points. Thank you.
So is that something that the local group will be looking at?
I think what I was trying to say is, unless we get the legislature to amend the statute, there's nothing that locally we could do to have that addressed differently.
But if you study it locally, you can approach the legislature with facts and observations. And so I guess that's where I'm coming from. And I know that's potentially a long process, but it would require policy changes for sure.
Sorry, was anyone going to respond to Ms. Cash before I jumped in with a question? I didn't want to cut anything off. So I wanted to flip back. I'm sorry, I didn't identify myself before. Darren Kennedy, community member. And this is actually related. Shay, thank you, because you actually presaged a little bit of my questions. So I've got, I think, some answer. But forgive me, I'm trying to wrap my mind around, Judge McCabe, what you were bringing up with the possibility of talking to Larned and looking at a model. You know, I can definitely remember, having grown up in Kansas with the closing of Topeka State Hospital and a bunch of other facilities, how this funnel has decades of history now. So I'm catching you there. I think what I'm trying to wrap my mind around is, anything that we would create, or when we talk about another model at the local level, or even this pilot project, is that all governed by that state statute? And does it have to be approved at the state level? Or is this something, when you talk about the conversations that you've had with Bob and thinking about another project, I guess maybe I'm asking in a ham-fisted way, how rogue can Douglas County go?
We can go, we can go completely outside the Larned default. As long as we have a program where people are restored to competency and they come back to court and the court can pronounce them competent based on valid evidence, the statute allows that. It's just this, it's a funding issue. Nobody else is stepping up. So Larned became the default and now we have the backlog and here we are. And, you know, to Jay's point, Douglas County doesn't have the highest criminal caseload in the state by a long measure, but we have the most people who are on that waiting list. That tells you that we have a pretty robust program here where people are being screened, I think appropriately, you know, appropriately, not being critical of other districts, but it reflects something about where we are and how we evaluate these things that I find positive. And we're in a district that may be willing to help explore those things. So, you know, Bob says we're not going to use the crisis center to achieve competency, not on a full-time basis, but because there's crisis options that as we're trying to look at these other ways of going forward, the crisis center can be a piece of that. That's what gives us the ability to start thinking. And that's why I say, if there's people who have other ideas, they're certainly worthy of consideration, but does that help answer the question?
Yes, yes, it does.
And I just want to add on to that just quickly. One thing that we have to remember when we talk about competency evaluation and competency restoration is that at the county level, we cannot force medications on anybody in the jail. If a doctor prescribes them this, you know, this very powerful anxiety med or whatever, you know, I'm not a doctor, and they say no, we say okay. However, when you go for competency restoration in the hospitals such as Larned, then they will go ahead and give you that medication. We do not have that authority, nor do we really want to. And but that is something that will have to be taken up as well, is at a county level, if we're willing to try to get to a place of competency restoration through our own projects, that is something that we're going to have to talk about deeply about what is our protocol going to be as far as these medications and that kind of stuff. Is it signed off by a doctor? Is it signed off by a judge? Because I'm not doing it otherwise. So that's just another layer that I just want to keep everybody kind of keep it in your mind that this is not as simple as just saying, okay, we're going to fix your here. Let's start the medication process, because it's going to be some work. So just wanted to throw that out. Thanks, Darren. You always have the best questions. I tell you, you're something else, man.
Hey, thanks everybody for the discussion. We're kind of running out of time here. Our next agenda item was with Melissa Nolte with Kansas Legal Services, and I don't want to cut you short, Melissa. Is there any way we can move you to March?
Yes, the presenter will be Marilyn Harp, our executive director,
Okay.
And that will be fine.
Okay, I appreciate that. I appreciate your flexibility. I want to make sure we have an opportunity for any public comment or public questions. Do we have anybody in the public that have questions today?
Yes, so I'm gonna let them speak.
Rick, I think you're on.
Can you hear me, Pam?
Yes, we can.
Yeah, I just wanted to add quickly to the discussion about competency. So in addition to the standards for competency evaluation and the protocols that you're considering for restoration at the local level, some of you are no doubt aware of the case Jackson v. Indiana. Our state statute, as I understand it, is based on the findings and decision in that case, which require the state of Kansas to establish a reasonable time period in which individuals who are deemed not competent to stand trial would have to have their cases adjudicated. And so it is, again, my understanding from the individual who wrote this statute that this essentially means that you can get 2 tries at Larned, after which you can't go back. And we know of individuals in Douglas County and elsewhere in the state who played that revolving door game back and forth between the jail and Larned. I don't have to go on about that. So I think as a point of information, we'd like to know, are there individuals currently in the county jail who have already been to Larned once for restoration and are now waiting for a second time? And are there people who are currently in the jail who have been twice, in which case that would be a violation of statute. The only options, as I understand it, is that they would have their case cleared and be returned to the community or civilly committed to Osawatomie State Hospital until their competency could be reestablished. But they could not be kept in jail indefinitely playing this revolving door game. So I think we need to know whether there are individuals in the jail population who meet those criteria. Thank you.
I can add a little bit of context to that. Mental health issues are a challenge in a lot of levels for criminal prosecutions. I heard very much what Shay was expressing in terms of the limits of some of that as actual legal defenses in Kansas. On the issue of competent to stand trial, the statute provides that once you are initiated into the competency restoration program at Larned, they have a 90-day window and they have to give you a prediction. I can't remember the exact deadline before I think it's 30 days before your 90 days is up. Do they think you're going to need to stay for another 90? Are you going to be able to be returned to competency? And if so, we can extend it another 90 days. So those are the two terms that I think Mr. Kagan is talking about. Now, if you go to Larned, because there was an initial concern about competency and you are restored to competency, that can be an issue that rears its head again, and then the process starts over. So the statute does not limit a court to one opportunity to evaluate somebody's competency. It's a fluid situation that for some people, as I said, manifests a concern. An evaluation is not at the local level. Nope, we're good to go. That can happen that can happen more than once. One of those may turn up, okay, this person needs to go to Larned. My history here is I have seen instances where the person has been to Larned twice. They haven't been restored. There's no likelihood that they will be restored. And that can tie into some of the things that Ms. Cash was mentioning. It can tie into a lot of different reasons. And then that person does go on a non-criminal track. But those are, I can think of two. And since I've been here as a prosecutor in 2006, and then on the bench since 2014. So, and I was the prosecutor in one of those cases where I said, look, we're not going to continue the loop. The statute says we've tried. He's not going to be competent. There's something else we have to do here. So.
Pam, just a very quick footnote to what the judge was saying. I think that one of the things that this committee ought to look at is when someone is coming back from a restoration experience and they've had a positive outcome, there needs to be some very close logistical coordination with the court to make sure that they're not sitting in jail decompensating for a couple of weeks before they hit the trial docket. Otherwise, it's just going to be a never-ending scenario.
Mr. Kagan, I don't know the perspective you're coming from, but I agree with it. And it's an area that those, and there's a role for everybody. That's a role for the attorneys, both the district attorney's office and the defense attorney, and there's different incentives for how those things play out. But as a general principle, it's certainly something the court should be mindful of.
Yeah, thank you for the opportunity.
Thank you. Zaina, is there anyone else that wants to make comment?
No, there's nobody else.
If we don't have anything else for the good of the order, I'm going to call this meeting adjourned, and we'll see everyone March 8th at the next meeting.